why I'm thinking about all this, because you're asking me to pick whether I pick up a TKI or this EP-nivo combination. I would tend to disagree with Nick when you said all these TKIs are equal. I think cabozantinib is clearly superior to sunitinib, established by a randomized trial with independent radiologic assessment. So my TKI of choice, I think, in first line is cabozantinib, and TKI of choice. And obviously, based on phase 3 data, randomized phase 3 data, nivo-EP should be the choice for most of the patients. But if I look at patients with bone metastasis, like Brad said, cabo is very superior, obviously superior to everolimus in METEOR trial, and I have no reason to believe why it wouldn't be superior to any other combination in bone predominant disease, where I'm really worried about progression-free survival benefit. And then, of course, the PDL negative patients, where there was no PFS benefit with EP-nivo combination. So if I see a high volume, rapidly progressive disease where I'm really worried about obtaining a PFS response or like progression-free survival, I think I would lean towards cabozantinib or a TKI in those patients, like the patient you said. Yeah. You mentioned, like Prisoner, who came with a big abdominal mass. He needed immediate palliation, and I doubt you would have chosen immunotherapy for that patient.
No, I'd never do that. You know, I mean, you need to know that what your disease parameters are. Right. I mean, I do respect the cabo data, but again, I keep coming back to it's a randomized phase 2. It's fairly small, and with all due respect to Tony and everyone else, it was a label expansion, right? I'm good with it. I love it. I haven't used it first line yet, but I think that we all realize that our choices there are good. The problem with Ipi-Nivo, until it gets on NCCN guidelines, I'm not going to get any insurance company to even look at me. And I can't give Nivo front line. I mean, maybe some people can, but I can't. Once we get the Nivo-Ipi, I'm going to reluctantly do it. Now, I'm actually eager to hear about the presentation of atezolizumab and Avastin.
And we're going to talk about that in the next section.
Good.
But I want to follow up on something that Neeraj said that I think is important, because I don't routinely check PD-L1 status in my kidney tumors. And yet, listening to you talk about this, it really sounds like knowing that PD-L1 status would weigh into your decision and how you'd manage these patients. I'm not saying it's the only factor, but it would be one of the factors in deciding which way to go, TKI or immunotherapy. Do you routinely check for PD-L1 status in your kidney cancer patients?
I wouldn't say I check for all the patients, but we do check PDL expression in many patients. The most important problem with PD-L1 expression testing is it varies among different kind of vendors. Like PDL testing may vary from one vendor to another. And that has been, I think, published recently in JAMA Oncology in lung cancer, from the lung cancer perspective. So that is challenging. But however, if I'm looking for any indication, any suggestion, any guidance on how to treat my patient, when I have 2 or 3 different options, I think I have to go with something which may not be very reliable, but if I have to compare in absence of a randomized comparison, 2 drugs, I think I like to use PDL testing.
Dan?
Yeah, Bob.
I think we learned from the Checkmate 025 that we cannot depend upon PD-L1 to give us the knowledge that we need to make the right decision. In the Checkmate 025, patients who received Opdivo compared to everolimus, whether you're PD-L1 positive or negative, patients still who received Opdivo did better, or nivolumab did better than receiving everolimus. With what we talked about, I think patients who present who have favorable risk, I would definitely think that I would just consider them receiving a TKI automatically. And again, in our practice, we do not test PD-L1, nor do we act upon it. I definitely defer that to my thoracic oncology partners. But for what I take care of in GU as well as for head and neck cancer, we do not need to have PD-L1 status to actually utilize our immunotherapies at all. So to date, and I agree with Dr. Vogelzang, I would not use the therapies of Ipi-Nivo until it's FDA approved. I would not use Nivo as a first-line therapy until it's FDA approved. But I still would not utilize that as a guide how to take care of my patients yet. We may have to when we have newer immunotherapies or other options that comes down the line. But to date, I would still treat our patients with favorable risk based upon how we categorize with the IMDC. I would treat them possibly as a TKI therapy. But short of that, I think for intermediate and poor risk, I would definitely consider, upon FDA approval, I would still use immunotherapy. And by the way, I don't believe that all immunotherapies work slowly. I think you may be quite surprised that if you actually have a patient and you give immunotherapy, they may have a significant symptomatic improvement within the first cycle of therapy. So I don't always think that TKI for bad symptomatic, bad toxicity of therapies, to me, it's more about I think mechanism may be quite beneficial to the patients.
Well, I think you're right. I'm a little bit worried about the immunotherapy because in the bladder world, we saw the chemo being better at the beginning and the immunotherapy sort of catching up. So I think every tumor is different. Certainly I've seen dramatic responses with Nivo within a week or two. There's no question in some, but it's not the routine.
Correct.
I think that's fair. And then finally, I think for TKIs, since that's still our standard for many of these patients, where are we? What do we choose? It sounds like, Neeraj has switched over to Cabo as his standard. It sounds like Brad is more in the Cabo camp. Nick?
No, I'm still a Sutent Votrient guy.
Bob, where are you?
So I've definitely have gone back. Well, so we were part of the Comparis clinical trial as well. I had 7 patients all randomized to sunitinib. So upon FDA approval, we jumped on the pazopanib therapy quite well, and our patients were doing better tolerability-wise. But then I was seeing not as a robust response as it was. So I've kind of adapted utilizing sunitinib again. Schedule changing different, using 2-1 rather than 4-2 my patients, and I find the tolerability is better. I find having half-time happen earlier is important, and I think the ability to have our patients maintain full dose on an adjusted schedule has given me the sense of accomplishing, again, a better response than what I was seeing on pazopanib. So I'm still more of a sunitinib gentleman as well.
Interesting. So there you have it, a real kind of split group.
I would add, though, that the frontline mTOR inhibitor story, that should be relegated to ancient history. I mean, there's no role for frontline mTOR in renal cell right now.
In poor risk.
Well, poor risk. That's
right. That's where its label is, right? Or it's where we look at it in terms of risk factors. And I agree with you. I mean, I think that when that study was done, it was really a different historical time. It wasn't even compared against TKIs. More recently, Nick, there have been some studies comparing mTOR strategies to TKI in this frontline setting. What are those results?
Yeah, it was from MD Anderson, Dr. Tenier. It was a small trial, pazopanib versus temsirolimus. And as in the sunitinib versus everolimus trials, pazopanib was clearly superior to temsirolimus IV. So I think that should not be used. I mean, that's, I noticed that sorafenib came off the frontline NCCN trials. Those are drugs that are sort of historically of interest, but not particularly relevant in today's world.
I still have one patient per year who always has poor insurance coverage that they have to receive intravenous therapy. And until Nivolumab is a FDA-approved first-line therapy, I'm still giving them temsirolimus as first-line therapy intravenously because financial toxicity is significant.
Or significant cardiovascular disease, where VEGF TKIs may be a problem.
Yeah. Again, to your point, Nick, it's nice to have options, but at the end of the day, I think you hear how our practices are changing, how immunotherapy is coming, how TKIs are evolving, how mTORs are kind of fading into the background, and I think that's going to continue, and hopefully that's helpful for you and your practices out there in looking at how to manage these frontline metastatic RCC patients.